On behalf of Indian Society of Hematology and Blood Transfusion, I welcome you all for the 22nd Masterclass lecture on M protein in blood. Is it myeloma? I invite Dr. and faculty for today's meeting, Colonel Dr. Uday Yanamandra sir, MD DMSS, DNB, MNA, MSDM, Clinical Hematology, Armed Forces Medical College, Pune. Over to you, sir.
Thank you. Firstly, I would like to thank the ISHBT for giving me this opportunity, and in particular, Maitri ma'am for considering me fit for taking this lecture for the day. So to make the class interactive, I would like the top 25 fastest finger to quickly log on to this particular search engine, because we'll have some live polls, and based on the replies that you people are going to give, we are then going to discuss the answers or the topic accordingly and clarify some myths and bust those. So the learning objectives for the day, for understanding the topic which was given to us, we need to answer few of these queries. So I have divided our lecture over the next 30-45 minutes into 10 modules, and we'll cover each module and we'll have a take-home message at the end of each module. So to start off with, we'll have first part, that is what is M protein. As you all understand, it's a paraprotein. The M stands for monoclonal. Some people also call it as a M component. Now, when we have to define an M protein, we all understand that all of us have got a polyclonal immunoglobulins in our body, which are a part of the humoral immunity. We define M protein as excess of a particular type of immunoglobulin secreted by abnormally expanded plasma cell clone, which is over and above the polyclonal immunoglobulin background that we all have. So the three important terms that all of us need to understand is the monoclonal, abnormally expanded, and plasma cell clone. Now, based on this, we can have three different types of M protein. One, we can have an intact immunoglobulin, that is a combination of a heavy and light chain. Then we can have only light chains, or we can have only heavy chains. Now, those people who suffer or who have a presence of M protein, they are known as monoclonal gammopathy. So, to define monoclonal gammopathy, these are those group of disorders which are characterized by proliferation of a single clone of plasma cells, which produces an immunologically homogeneous protein referred to as M protein. And as we just discussed, the word or the term M stands for monoclonal. Now, the whole story revolves around a plasma cell. So the aspect that needs to be discussed is, what is a plasma cell? Just a quick fact about what is plasma cell. Now, the primary role of a plasma cell in the body is to play the key crux in the humoral immunity. Normally, they are generally 3 to 5% in the marrow or in the reticuloendothelial cells, and you don't generally find these cells in the circulating blood. And as you could see in the photograph here, these are oval-shaped, deeply basophilic cytoplasm with a perinuclear halo, which is characteristic for that. And the nucleus is generally eccentric, and it has got a coarse chromatin known as a clock face pattern. Now, going to the next part. This is a normal plasma cell development. We'll not dwell into this much. We'll discuss about it when we come to the pathophysiology of individuals who have got M protein. Now, at the end of the first module, what we need to understand is the M stands for monoclonal. These come from expanded clonal plasma cells. Now, coming to the second part of it, after we understood what is M protein, the next question is, how do we diagnose M protein? So there are three basic modalities based on which we come to a diagnosis of M protein. The primary of them is a serum protein electrophoresis. Then it needs to be qualitated by doing an immunofixation, and in certain cases, a free light chain assay. So first, the protein electrophoresis. Now, as you see the first panel, which is here, and you would see that these patients generally, they have got a normal albumin, alpha 1, alpha 2, beta, and a globulin region. In individuals with acute inflammation, there will be a rise in the alpha 1 and the alpha 2 parts of this electrophoretic pattern. In patients with alpha 1 antitrypsin deficiency, you will have a low alpha 1. In individuals with liver cirrhosis, you will have a hypoalbuminemia and a polyclonal rise in the gamma component. Now, when you are looking at individuals which is particularly the multiple myeloma, you will find that there is a peak which is present here, and this peak is the gamma peak. And in individuals in nephrotic syndrome, there will be a low albumin and there will be a rise in alpha 2 beta and a low gamma. I'll show you the same in individuals with different serum protein electrophoretic patterns. Now, you could see here all those which are labeled as blue color here in the graph are the ones which are the abnormal components. The arrows show what rises and what falls in different conditions. Now, when do we do protein electrophoresis? Do we do it in every individual? No. There are specific indications for doing protein electrophoresis. The first and the foremost indication being patients with elevated total serum protein or those who have got albumin globulin reversal. There are many benign causes for AG reversal also, but generally the patients who have got AG reversal and aged above 40 years, they should be subjected to protein electrophoresis. Second, where you have a suspicion for any of the plasma cell dyscrasias as labeled here, they are the indications for protein electrophoresis. Lastly, at the bedside medicine, individuals who have got unexplained anemia, backache, osteolytic lesions, spontaneous fractures, kidney impairment with bland urine sediment, those individuals who have heavy proteinuria and particularly above 40 years of age, individuals with hypercalcemia, hypergammaglobulinemia, immunoglobulin deficiency, particularly hypogammaglobulinemia, Benz-Jones proteinuria, unexplained neuropathies, recurrent infections, and those individuals who have got mega ESR defined as more than 100, and a patient with features of increased blood viscosity, repeated headaches, nausea, and associated with giddiness are those individuals where you can subject them to protein electrophoresis. Now, after we have done protein electrophoresis, this only gives you a quantitative estimation. It needs to be qualitated or qualified by using something known as serum immunofixation. Now, the indications for serum immunofixation are those patients who have got a sharp band or a peak in the agarose gel protein electrophoresis, they have to be subjected to immunofixation. Now, there are a few queries before we go ahead with the immunofixation. Now, do you require SIFE if you have a positive SPP at diagnosis? The answer is yes. And why do you require it? And what is the difference between SIFE from protein electrophoresis? Now, immunofixation uses antibodies against the light and heavy chain. Thus, it becomes more sensitive and it can even detect minor M proteins which are actually missed in patients with SPP. The second part is it is qualitative, whereas SPP is quantitative. So, to identify the type of the protein, we need to do immunofixation. And to quantify the amount of protein, we require protein electrophoresis. So rather than saying they are a replacement for each other, they are actually complementary to each other to understand exactly the pathophysiology which is happening inside the body. Now, the sensitivity for serum M protein is up to 0.2 gram per liter or 0.02 gram per deciliter. Whereas in urine, it has got a higher sensitivity and we can detect up to 0.04. So those individuals where we strongly suspect that the patient has got a paraprotein and we are not able to pick it up by protein electrophoresis, they can be subjected to immunofixation. The other indications are similar to what we have seen for the protein electrophoresis, wherein we are suspecting a dysproteinemia or a plasma cell dyscrasia. Despite having a normal SPP pattern, we can do a immunofixation. And second, other than those where symptoms and physiology where we have seen, wherein unexplained signs and symptoms, additionally, in those individuals who have got a refractory heart failure, orthostatic hypertension, carpal tunnel syndrome, or malabsorption. Now, all these four are actually features for amyloidosis. So, in those individuals, we can do immunofixation, even with patients with normal protein electrophoresis. Now, there are some other indications other than these labeled indications for immunofixation. One, detection of very small protein in the presence of normal or increased background immunoglobulins. So let's take a patient who has got a connective tissue disorder or a background inflammatory condition. So there will be a polyclonal rise. So sometimes a small M protein can get missed by protein electrophoresis in such individuals, whereas immunofixation will still detect such patients. Second, in patients with multiple myeloma or Waldenstrom's, in whom after the treatment, the protein levels have gone so low that you are not able to identify them on a protein electrophoresis and you want to monitor your therapy, then immunofixation is a better modality than protein electrophoresis. Thirdly, we have certain disorders known as a biclonal or triclonal gammopathies, which have a different prognostic implications. I'll show you some figures. Now, this is a figure wherein a patient has got IgM plus IgG disease. Second, I'll show you a triclonal gammopathy where the patient has got three particular disorders, IgA, IgG, and IgM here. So, where you have got a biclonal or a triclonal gammopathy, there again, immunofixation is better than protein electrophoresis because protein electrophoresis cannot differentiate a normal paraproteinemia versus a biclonal or a triclonal gammopathy. The third test that we are going to talk about is light chain assay. Now, previously, we used to do something known as a total light chain assay, wherein we used to pick up those light chains which are intact or with the heavy chains, those which are coupled and those which are free. But lately, we have started using, or the ideal way is to do for a free light chain assay. The word free means basically the light chain epitope which is there. So the dark red colored band that you are seeing here is the epitope on a light chain. They should be exposed. So those light chains which have this epitope which is exposed are the ideal way for monitoring it. And these are the free light chains. And these are the most standardized version for monitoring a patient with a myeloma or a plasma cell dyscrasia. So the ideal way of doing a free light chain, the best testing assay is free light, which is based on a UK binding set. Nowadays, we have got additional tests available, which are also being standardized and are being used. And here in this particular testing, they use multiple antibodies for kappa and lambda chains, and they have got a higher sensitivity and specificity when compared to the previously used other light chain assays. Now, let's quickly go to a small case vignette, which I'll give you. Now, there is a 54-year-old male. He was found to have a negative protein electrophoresis, and the whole gamma globulins was less than 6 grams per deciliter. But the patient was found to have renal dysfunction, was found to have anemia and lytic lesions, and later a bone marrow showed more than 10% of plasma cells. And the patient was labeled as newly diagnosed multiple myeloma. The graph that you are seeing is this protein electrophoresis. Now, can you type down in this particular poll, why do you feel that the patient does not have an M protein in this case? Already somebody has typed, but I would like to wait for 5 seconds to look for the other answers. You can just use any search engine and put pollev.com/udaywai638 and you'll be able to type your answers. So why do you think that this patient does not have an M protein despite having such an overt disease? Now, a request for all the residents or the students who are participating here, the more you answer, the better it would be for us to understand that what are the myths and what we need to bust those myths. Okay, somebody said light chain myeloma. Okay, very good. Anything else? There is a possibility that this could be a light chain myeloma because light chain myelomas might not be picked up by a protein electrophoresis. So what I'll give you is, based on this answer, I'll give you one more graph. Now, the second graph shows that the patient does not actually have got a light chains also excessive. So even we are missing that, except for a mild kappa chain. So the light chain myeloma is okay. But can you see something specifically in the gamma region, which is leading to a problem here? So if you look at the graph, what is happened to the gamma region? Okay, I'll go ahead. So this is generally the gamma region that you see in patients with hypogammaglobulinemia. Now this is suppressed. So as you see, I have put 2 patients' graphs below. So if you look at the first graph here, so you could see that the gamma region is totally flat. Now, even in the second patient, you could see that the gamma globulin region is flat. So these are the areas where you look for a gamma globulin region. Now, there is a condition known as a hypogammaglobulinemia. Why we are discussing this is one of a very common problem in patients with plasma cell dyscrasias. So we define it as whenever the gamma globulins overall is less than 0.6 gram per deciliter or 6 gram per liters. So it is characterized by a decrease in the size of the gamma region. And basically what it does is, now it can be caused by multiple problems, primarily myeloma, AL amyloidosis, CLL, lymphoma, nephrotic syndromes. So the incidence is up to 10% in patients with multiple myeloma and 20% in patients with AL amyloidosis. It is because of a condition known as the immunoparesis, which takes place in patients with plasma cell dyscrasias, wherein the normal or the normally producing immunoglobulins are suppressed by the clonal plasma cells, thus leading to overall non-selective globulin loss. Now, it can also occur in nephrotic syndromes where because of the proteinuria, a patient can actually have a low gamma globulins. The important aspect is in these patients, you can find a negative protein electrophoresis. So it is very important when you have a high clinical suspicion of a plasma cell dyscrasia and your serum serum protein electrophoresis or a serum immunofixation is coming negative to subject the patient for urine protein electrophoresis or urine immunofixation. Now, over a period of time, over the last 4-5 years, people have lost the habit of getting a urine protein electrophoresis or a urine immunofixation. But those patients who have got active kidneys and are successfully able to excrete the various abnormal proteins, the serum might be normal and the urine might show a very good and a avid band on an electrophoresis. So you won't miss such cases. So whenever you strongly suspect, please get a SIFE done, serum immunofixation, or a urine protein electrophoresis and urine immunofixation. So at the end of the second module, the ideal tests that we need to do in individuals with a monoclonal gammopathy includes a triad of protein electrophoresis, immunofixation, and free light chain. And hypogammaglobulinemia needs to be considered when you have a high clinical suspicion and the patient is not showing a protein electrophoresis band. Let's go to the next module where we talk about what does a M protein imply. So when we looked at all adults above the age of 50 years, up to 3% of these individuals can have a monoclonal gammopathy or an M protein. If you look at individuals above 70 years of age, the percentage can be as high as up to 5%. Generally, the frequency is IgG is more common when compared to IgM, which is more common than IgM. It is either because of the plasma cell dyscrasias, it could be because of autoimmune disorders or chronic inflammatory disorders, which can lead to a mild M spike in individuals. It need not be mandatorily a neoplastic condition, but we have got a huge era of the benign conditions which can lead to a M protein. Now, the distribution of the monoclonal gammopathies based on the Mayo Clinic experience, wherein they are compiled from 1974 to 2004, various patients, you would find that the myelomas constitute only 15% of these individuals. Huge number of people have got a condition known as MGUS, which we'll discuss in the next few minutes. But it could also be, the point which needs to be understood, it could also be because of lymphoproliferative disorders, it could be because of macroglobulinemia and multiple other disorders. If somebody has to tabulate all these causes, you would see that this is a huge number of disorders which can lead to M protein. So answering the question or the title of today's masterclass, is M protein always myeloma? No. It would be only the first top paragraph on the left-hand side, which would be the plasma cell dyscrasias, but you can have multiple other disorders which can lead to a presence of M protein. Now, I can understand it would be very difficult for the students to by heart or remember all these causes. So let's look at it pathophysiologically. Now, whenever a patient has got some genetic abnormality or a genetic hit at a germinal center, that leads to accumulation of clonal plasma cells. Now, these clonal plasma cells, generally, they have got a second hit or a second condition, which is generally environmental in nature, which converts these clonal plasma cells into clonal malignant plasma cells. Now, Thus, after a first and a second hit, an individual can develop a smoldering myeloma, a overt myeloma, or extramedullary disease, or a plasma cell leukemia. So the first cause or the first paragraph of the table was about plasma cell dyscrasias. So you can have all these plasma cell dyscrasias develop over a period of time based on accumulation of clonal malignant plasma cells. The second issue is, now when you look at plasma cell generation pathophysiologically, so they are originated from lymphoid stem cells to lymphoblasts to B lymphocytes to plasma cells. So if you look at this particular arm of the development of plasma cells, any problem in lymphoid stem cells to lymphoblast to lymphocyte can lead to a accumulation of plasma cells and M protein. So these conditions include non-Hodgkin's lymphoma, CLL, lymphoplasmacytic lymphoma, post-transplant monoclonal gammopathies, and heavy chain disorders. Rarely, even Hodgkin's lymphoma have been said to develop a M protein in some odd case reports. The next group of disorders, as you have seen, that it is the B cell which leads to differentiation to plasma cell. So anything which leads to proliferation of the B cells can lead to a M protein formation. So connective tissue disorders, a huge number of them, and infections can lead to rarely presence of M protein. But you also need to understand that few of these connective tissue disorders and infection can have an underlying lymphoproliferative or a plasma cell dyscrasia associated with them. Now, coming next after this would be about M protein always does not mean myeloma. You can have a B lymphoproliferative disorders or benign inflammatory causes which can produce a M protein. So that's the end of the take-home message from the module number 3. The next module that we are going to discuss about, after we have discussed that M protein is not equivalent to myeloma. So are there any lab errors, false positives or false negatives which can lead to presence of M protein? And this we'll discuss using some case vignettes. So here I would request all of you to kindly participate in this poll so that we can clarify your queries and your answers accordingly. So let's look at the first case. You are working in a biochemistry lab. A Pellane vacutainer was handed over for SPP, but the sample was collected 12 hours before, and you could clearly see that the sample was hemolyzed. The SPP was run on an agarose gel, which revealed these bands as shown by the red arrows here. The immunofixation does not show any evidence of monoclonal protein. What are these bands because of? So why do the individuals have these bands? Okay, anything else? So would it be only plain hemoglobin which have led to this band? And does hemoglobin reflect in a protein electrophoresis? Or are we looking at some complex of hemoglobin with some other protein? Okay, I'll respect this answer. I'll give marks for this particular point. So yes, it is a hemoglobin, not exactly spectrin, but it would be a hemoglobin haptoglobulin complex, which are generally formed in gross hemolysis. And these are the ones which actually can be seen in the alpha 2 and the beta regions. And also it depends upon the type of the gel that we are using. If there are any biochemistry students here or hematopath students, they would understand. We have two types of this gels, a split beta gel versus a single beta gel. So based on the type of the gel you are using, it can be shown in the alpha 2 or the beta regions as shown in the figure here. So in hemolyzed samples, we should be doubly careful before we label an individual having a M protein. Okay, next case vignette. A serum sample has an additional band of approximately 3 grams per liter. You can see that as shown in the blue arrow here in the graph A. Now, IFE does not show any monoclonal immunoglobulin. And this particular band disappears on adding thrombin and repeating the protein electrophoresis. So what is this band because of? If we have some hematopath residents here, they can easily identify the answer. with particularly the clue that these people, they have the disappearance on adding thrombin. It is a part of the coagulation cascade, but not antithrombin, but something closer, other component of the coagulation. Okay, I'll not waste time. So this is fibrinogen. So fibrinogen in individuals who have got high fibrinogen, they can be reflected as particularly having particular type of a band here. Wonderful. So correct answer, it's a fibrinogen. You immunofixation, and the graph B shows you actually isoelectric focusing. So what do you think? You see that these patients have got actually a focal band in the gamma globulin region, consists mainly of antibodies. So if you look at the connecting light chains, the patient has got both kappa as well as lambda. And in the last one, if you look at the isoelectric focus, so you will see that the patient in this, it closely mimics a patient with plasma cell disease. And we need to be very careful in diagnosing such cases. Going to the next case, we have a 58-year-old male who came the SPP showed discrete band in the. Yeah. So I was saying that basically we can have the contrast, various contrasts, which can lead to problems as far as the SPP interpretation is concerned. So there are various reasons which can lead to false positives for protein electrophoresis. One is hemoglobin haptoglobulin complexes. Second is fibrinogen, which can lead to a problem. Sometimes in severe iron deficiency anemia, the transferrin can be localized in the beta region. Patients with IgG4 can have a relative restricted band in the beta region. The nephrotic syndromes can have an increased alpha-2 and beta, which can be mistaken for the M proteins. Acute phase reactants can sometimes lead to it. And most importantly, the commonest artifact is the point of application of the sample. If the sample is not properly applied on an agarose gel, that can lead to abnormal bands. Now, coming to the next question, we have got a case of relapsed refractory multiple myeloma with IgA lambda disease on daratumumab-based therapy and was subjected to protein electrophoresis and immunofixation. The results are shown here. Now, this patient, as you can see here, has a persistent band in the SPP as well as in the SIFE. What do you think it is? Is it because of daratumumab? Is it because of the relapsed refractory nature of the disease, or it is either? Okay. Now, whoever have answered it as daratumumab. But why do we think so? So the clues which are there in this particular case are the patient initially had a lambda disease, whereas you are seeing a kappa here. So yes, there is a possibility that it could have been a clonal evolution, but the points which are clue are all the therapeutic monoclonal antibodies are generally IgG kappa in nature. So when you have a IgG kappa coming up in the protein electrophoresis in a known patient with lambda disease or with any other heavy chain, then you should consider it to be secondary to therapeutic monoclonal antibodies. And the options which are available to us are daratumumab specific immunofixation electrophoresis reflex assay or a mass spectrometry, which can actually allow us to identify whether it is because of the monoclonal antibody or is it because of the disease per se. Now, please understand, the same concept does not apply for other monoclonal antibodies like infliximab, rituximab, eculizumab, various other antibodies that we use. And also the autoantibodies which are there in the body, they generally don't produce M spike. Coming to the next case, we have a case of myeloma with normal SPP and SIFE. So these are the the SPP reports of a patient before treatment and after treatment. So which varieties of myeloma are generally missed on both SPP and the routine SIFE, wherein we do it for gamma, the M, IgM, IgA, kappa and lambda. These are the common 5 antibodies that we use. So what are those diseases, those types of myeloma which are missed on this? Okay. So anyway, people have not answered it yet, but generally the IgD and IgE type of myelomas are the ones which are generally missed upon with the normal protein electrophoresis and the normal 5 combination immunofixation that most of us do. So when there is a suspicion of a patient having a strong suspicion of plasma cell dyscrasia and you are suspecting IgD or IgE, then the lab needs to be specifically informed so that they can put the antibodies for that. Okay. We generally have heard of M protein in the serum and the urine. Now, this is a trivia question. In which disease M protein can be found in jejunal fluid, but not in serum and urine? So the answer for this is generally in patients with heavy chain diseases, you can actually find the patients having a M protein in the jejunal fluid. So coming up quickly, these were all the cases wherein we were talking about the false positives. Now also look about the false negatives. So a small M protein can sometimes be missed. IgD, IgE can be missed. In heavy chain diseases, you can generally have a false negative protein electrophoresis. In patients where there is a polyclonal pattern, wherein the IgM has dimerized or pentamerized, or IgA has a polymerized, there you can have a false negative. And also, as was rightly labeled by the people in the one of the question, that when we have light chains, there we can miss those individuals on a protein electrophoresis. So at the end of the module 4, we have various false positives as the negatives for the M protein, and it needs to be interpreted very carefully. Now let's come to the most important aspect or the primary question of the talk for the day, that is M protein in blood. Is it myeloma? So this, for answering it, the answer is simple. The presence of mere M protein is not myeloma, but for calling it as myeloma, we require to have either M roti, slim crab, or a myeloma defining events. Now, the diagnostic criteria of myeloma, initially, when we were undergraduates, it used to be bone marrow more than 10% clonal plasma cells with CRAB criteria. So the first component of the diagnostic criteria was about a plasma cells. Now, that brings us to the question, the relevance of bone marrow in patients with multiple myeloma. So let's take a patient who has got a very heavy M protein and he has got CRAB criteria. Can I avoid doing bone marrow in such individuals? So, and when I do bone marrow, how do I quantify the plasma cells? Because here I have told that the quantification is, we are saying that the quantification is more than 10%. So let's take on aspiration, there is a quantification of 34%. On bone marrow biopsy, your pathologist tells you that there are 50%. And on flow cytometry, he says that there are 72%. Which of these numbers will be picked up by you people, whether 34, 50, or 72? So the correct answer for this is 50%, because among the aspirate and the biopsy, the highest of the numbers is taken for calculating the plasma cell percentage. And we don't use the flow cytometric percentage for enumerating the plasma cell percentage. So the percentage, whenever it is more than 60%, it itself is a separate criteria, and the patient does not require any other CRAB criteria or any other myeloma defining events for labeling a patient as multiple myeloma. So it's very important to enumerate plasma cells percentage correctly in the marrow. Now, the second question is how to quantify, is it just the plasma cells percentage or anything else which is important? So the answer for it is clonality. You can have reactive plasma cytosis in, particularly in our country, in patients with tuberculosis. Many of us would have seen patients having 20-25% plasma cells in patients with tuberculosis or aplastic anemia. So till the time they are not clonal population, a mere percentage of plasma cell is not sufficient enough. The next aspect is the relevance of flow cytometry in multiple myeloma. So it is important for identifying the clonality and also to differentiate plasma cells from lymphoplasmacytic cells. Now let's take a patient has got a M protein positive and the free light chain ratio is 34.2. Do we require myeloma now in this patient? The answer is yes. The percentage of plasma cells are required in the marrow still, because you still require more than 10% of the plasma cells. And second, cytogenetics for risk stratification is extremely important. So we have a cytogenetic panel, a minimum panel of these 5, wherein we do TP53 monosomy 1, 414, 1416, and 1420. They guide us through the prognosis of the individuals and also try to tell us which type of therapy would be ideal in given individuals. So a marrow is very, very essential. Now, what are those conditions where marrow aspiration is not required for basic diagnosis? So there are certain conditions wherein if a patient has got a proven plasmacytoma, wherein a tissue biopsy from any of the plasmacytoma shows more than 10% of the plasma cells, and the patient have got associated CRAB or a myeloma defining events, then we don't require a bone marrow in those individuals. But still, we generally suggest bone marrow in such individuals for getting the cytogenetics still in these individuals. So as a rule, all the students should remember that every patient of plasma cell dyscrasia or myeloma should be subjected to a marrow. Now, the second aspect is the CRAB criteria. Now, these are the incidences of the CRAB in our country. They are much, much higher than what they are generally reported in the West, because many of our patients get diagnosed or detected quite late. So let's come to each one of them. So the renal dysfunction, how do we define a renal dysfunction in myeloma? So a creatinine of more than 2 milligram per deciliter or a GFR of less than 40 is defined as R positive. The incidence is around 20% in the West and 58% in the India. And lately, people have shifted from creatinine to eGFR, wherein they say that it actually identifies patients earlier and much better when compared to using just creatinine as a criteria. Second, coming to the anemia, a hemoglobin of less than 10 gram per deciliter or a fall of 2 gram per deciliter then the last normal is defined as anemia. And again, the incidence is much, much higher in our country. And during the course of illness, almost 100% of the patients have anemia at certain point of the disease. Generally, it's normocytic, normochromic in nature. And the causes remain to be bone marrow replacement or the renal dysfunction in patients with myeloma. Lytic lesions. Now, there are a few questions when we talk about lytic lesions. What is the ideal diagnostic modality? Because there has been a lot of misuse, or I would say abuse, of PET-CT in practice nowadays. So what is the role of skeletal survey on today's date? What is the role of PET-CT and what is the role of MRI? So first, coming to skeletal survey, it is very important for all the residents to understand what all is included in a skeletal survey. So we have AP and lateral views of the skull. We have PA view of the chest, AP and lateral view of the cervical, thoracic, and the lumbar spine. We have AP view of the humerus and the femora, the two long bones, and AP view of the pelvis, which is the largest flat bone in the body. So these are the various X-rays which have to be done together to call it as a skeletal survey. Doing it patchy is not adequate enough. Now, what is the relevance of PET scan? Should we do it in all patients of myeloma, or is there a relevance in diagnosis or monitoring, and how to score it? So it is not required in all the patients of myeloma. So those patients who have got lytic lesions on X-ray, there is no added benefit of doing a PET scan. In the same way, if a patient has got MRI done for any purpose and you find that the MRI shows lesions which are more than 5 millimeters in size, then again you don't require a PET scan. When compared to PET versus MRI, the MRI is beneficial at diagnosis and PET is more beneficial in the monitoring. And PET also helps in MRD analysis as a supplement or a complementary test to the flow cytometry. So PET has a role as far as the monitoring is concerned. And we have scoring known as a PIPETM or an impetus scoring, which are used for scoring the PET in case of myeloma. Now, lately, there have been something which has been added known as a myeloma defining events. Now, people can say, when we were already diagnosing patients well with CRAB criteria, why is the requirement of these three additional criteria, which are also known as a SLIM criteria, where S is for the more than 60% clonal plasma cells, the LI is the light chain, wherein the ratio more than 100, and the M is for the MRI showing more than one osteolytic lesion. There is a reason for it. When we have the patients of smoldering or the monoclonal gammopathies, you find that they keep progressing over a period of time. And when you look at the reason for progression, they could identify three primary causes. Those patients of MGUS or smoldering who have a ratio more than 100, who have a clonal plasma cells more than 60%, and who have MRI focal lesions were those who definitely progressed and had a poorer prognosis. So they said, rather than waiting for the end organ damage to occur, why not we pick up these patients much earlier using one of these three criteria and start treating them earlier rather than waiting for the end organ damage to occur. So thus, the previous criteria of CRAB got shifted to SLIM CRAB, wherein we have all these criteria associated with it. So these are the latest guidelines as far as the diagnosis of myeloma is concerned. So coming to the end of the module 5, wherein is all M protein in the blood myeloma? No, we require SLIM CRAB or myeloma defining events along with 10% plasma cells in patients with M protein for diagnosing them as myeloma. Now coming quickly to the next aspect, what if M protein in the absence of myeloma, overt myeloma? So first thing that you need to do is to rule out B lymphomatous processes or the benign inflammatory conditions. So this is the natural history of the myeloma, and there is something known as a monoclonal gammopathy of unknown significance. So where you have got M protein which is present and patients do not have a slim crab criteria, do not have a B lymphomatous process or any other inflammatory causes, they fit into this condition known as a monoclonal gammopathy of unknown significance. Now, the average prevalence of it is around 3.2%. It is higher in men when compared to the females, and the IgG is the commonest variety out of all. There was a recent study which was published in the ASH 2022 when it was presented in the last ASH in December, wherein they found that prevalence might be much higher. The previous prevalences that we were talking about were all only US or the Mayo Clinic based. So they did a study in 84,000 people and they found out that the incidences are much, much higher and it keeps rising with the age. And as you would see in patients more than 80 years of age, it can be up to 11% can be having a monoclonal gammopathy. And generally, they all have very small M proteins and not overt proteinuria, M proteins. And when you look at the type of protein, it coincides with that of the US data, wherein IgG happens to be the commonest variety. So the first part we were talking about is the MGUS. So there are different types of MGUS, IgM MGUS and non-IgM MGUS. Why they are divided into these subtypes? Because out of all the types of MGUS, those who have IG, how many risk factors are available, we divide them into low risk, intermediate risk, or high risk individuals. And based on this, we have further monitoring and evaluation, which can be guided. Now, these are the different risk factors. As you could clearly see in this graph, those people who have got all three risk factors present, they have almost 60% chances of progressing to myeloma over 15 years of time. So that's why this risk scoring is important. Now, shifting gears from myeloma monoclonal gammopathy of unknown significance to monoclonal gammopathy of renal significance. Now, this was a term which was introduced in 2012, wherein it is an umbrella term for all the pathological renal damage, which is attributable either directly or indirectly to the monoclonal protein. And we can have different types of MGRS based on where the protein is getting deposited. Is the protein getting deposited in the glomeruli? Is it getting deposited in the tubulointerstitial space? Or is it getting deposited in the intrarenal vascular compartment? And based on that, we have different types of MGRS which are being described. There is another term which is known as the monoclonal gammopathy of clinical significance. Now, you could find that the monoclonal protein can get deposited in the skin and can lead to xanthomatosis. It can lead to cryoglobulinemia. It can lead to bullous skin lesions, or it can lead to cold agglutinin diseases. It can get deposited in the peripheral nerves and can lead to peripheral neuropathy. It can lead to Poems syndrome. It can lead to Sweet syndrome, or it can lead to scleromyxedema. It can get deposited in the eyes and can lead to crystalline keratopathy. Now, these are all those places where the clone is very small in size. The plasma cells are less than 10%. These people do not have slim crab criteria, but they do still have certain clinical manifestations. And we really don't know how they progress over how much period of time to overt plasma cell dyscrasias. So these are known as monoclonal gammopathy of clinical significance. So to complete this module, there are various pre-malignant or precursor states, namely MGUS, MGCS, or MGRS, wherein there is M protein, but there is no overt myeloma. Now, there is another condition which is lying in between MGUS and the overt myeloma, which is smoldering myeloma. So let's quickly talk about smoldering when M protein is present in the absence of myeloma. So this is defined by the IMWG by the following criteria, wherein the M protein is more than 3, the clonal plasma cells are between 10 to 60%, but there is no slim crab criteria. Now, these are those individuals who have higher chances of conversion to a overt myeloma, up to 2% per year. People have tried to identify among the cases in smoldering those who have a high risk of transformation versus those who have low risk for transformation. And there is a rule known as 20-20 rule, which means people having plasma cells more than 20%, M spike more than 2, and free light chain ratio more than 20. So if an individual has got a 20-20 present, all three risk criteria, they have got very high risk of transformation and the median time to progression is 29.2 months or approximately 2.5 years. Whereas those who do not have any of these criteria, their average conversion over to a overt myeloma is almost up to 10 years. So the student should remember this 20-20 rule. And those people who have high risk, there are multiple studies which are trying to evaluate the role of therapy by using either lenalidomide in combination with dexamethasone or lenalidomide alone to prevent the progression. But as on date, there is no clear guidelines on treating patients with high risk smoldering. We only treat patients who have got overt myeloma. So the consensus as far as the treatment of smoldering is, when any patient has got any of these high risk criteria, they are supposed to be enrolled into a clinical trial, and thereafter they can be put to any of the therapies. Now, there have been several concurrent high risk features and evolving M protein, wherein the patient has got rapidly rising M protein. Those are those small cases wherein there are trials to suggest that they might get benefited, but nothing as of date suggests treatment for smoldering. Now, this is a suggested recommended follow-up. So at the end of the module 7, we would say that people, the precursor states of smoldering also needs to be monitored, but not treated as of now outside clinical trials. Now, what if M protein is positive and how to proceed with the testing? So the testing in any patient who has got an M protein undergoes 3 different phases. One is to confirm monoclonal gammopathy. Second, to characterize the type of the disease. And third, to prognosticate the disease. Now, in ideal settings, if at all, if we are practicing in resource-rich situations, then you have a huge list of diagnostic and prognostic tests, which includes whole body low dose CT or PET-CT, NT-proBNP, FISH markers, plasma cell phenotyping, plasma cell proliferation. And in fact, it also suggests NGS panel testing for all these individuals. But the factor is, which needs to be understood, is what in resource constraint settings. So among these, all the tests which I have shown you, which are state-of-the-art workup, there are certain tests which can be avoided in resource constraint settings. So I've actually dimmed all those tests which can be avoided. And you can just restrict to the tests which are shown in the dark black and forget all those which are shown in the gray color. Now, the same thing is also reflected in the NCCN guidelines, which have come out with resource-based adaptation for sub-Saharan Africa, and we almost fit there. Now, in our scenario, I'll give you a small flow chart. So for the confirmation of the monoclonal gammopathy, people can do SVP, 24-hour urinary protein immunofixation. If negative, do free light chain. Bone marrow aspiration biopsy, look at the morphology. If the morphology shows flow-ploidy or proliferation, then go ahead with the FISH. In disease characterization, do a skeletal survey. If it is negative, then subject to a whole body low dose CT or a PET-CT. And for prognostication, LDH and beta-2 microglobulin, which are universally available in our country, can be done. So by doing this algorithmic approach, we can actually cut down many of the tests, because we in our country don't either fit into a totally resource rich or don't either fit into a sub-Saharan situation. So we are somewhere in between. So rather than avoiding certain tests, we can do an algorithmic approach for doing these tests. There are some additional tests which would be required, particularly renal biopsy, tissue biopsies, EMG studies, and echocardiogram, when you have got certain other clinical findings which are as shown here. So coming to the end of this 9th module, we can avoid few tests and make it cost effective, and every particular institute, based on the cost of the test, can come out with their own algorithms. And in India, one size does not fit all. So every institute or every particular given geographical area should come out with their own algorithms. The last part, which I'm going to talk for the days, is screening for M protein, a solution for lesser complications and early diagnosis. Answer is no, because though we understand that the percentages are quite high as the people keep aging, we understand in our country there are now many executive health checkups being offered by many competitive pathology labs in the private setup, where they have included protein electrophoresis for any individual above 50 years of age. As of now, it has got no role. It should be restricted only to research settings and not for day-to-day clinical practice. Yes, it can be of role in those individuals with strong family history, where the individuals have got high elevated protein, reversed albumin globulin ratio, unexplained renal insufficiency, high ESR, hypercalcemia, etc., etc. More than screening, it is better to educate the general physicians, the MD medicine and the MD pack people, the nephrologists, the neurologists about the relevance of the M protein and when to pick up myeloma and when the patient does not have myeloma. That will have a better advantage rather than screening everybody for the M protein. So screening is only for the research purposes, and as on date, there is no role in the clinical practice. So I complete my class with the following take-home messages from the different modules that we have spoken about, and I would be more than happy to take if there are any queries. Yeah, Mr. Praveen, can we have any queries?
So just a moment.
Yeah.
Sir, there is one question from Dr. Anita Jain. Should PM aspirate done in OPD or taken up at tertiary center?
Okay. Yeah, that's a very nice question. I would say that the bone marrow aspirates can be done in any of the OPDs, but people just need to understand two important aspects. As long as the complete panel of the test from the bone marrows are sent at the peripheral center, it is perfectly okay. So you should definitely include a flow cytometry and a FISH panel when you are suspecting a plasma cell dyscrasia. So if that is taken care of, then the patient need not be subjected to a repeat bone marrow at a tertiary care center. But generally, the problem which happens is people undergo bone marrow at a peripheral center, wherein it just is subjected to an aspirate and a biopsy. And then we have to repeat it for the FISH panel or for the cytogenetic panel. So if they can be included upfront, then we don't need to refer the patients to tertiary care centers. But that's a very nice question, ma'am. Okay, Dr. Radhika, what is the best radiological modality for skeletal survey if finances are not an issue? Okay, so point is there is a debate between a PET CT versus a whole body low dose CT. If finances are not an issue, I personally would go ahead with a PET CT because that helps us in understanding the baseline value for monitoring it in the future and comparing from the future evaluation. And more importantly, it also gives you about extramedullary disease. So extramedullary disease is one thing which cannot be picked up by a whole body low dose CT. But many centers, I understand on today's date, many institutes of national importance subject as a routine their patients to whole body low dose CT vis-a-vis skeletal survey. So PET CT is a step better when compared to a whole body low dose CT. Okay, why not whole body MRI? Now, a patient undergoing whole body MRI again will not give you an idea about extramedullary disease. It is okay, good to identify the lesions, but it does not help you with the thing. And the time which it takes for a whole body MRI is huge. So put together MRI versus PET CT, a PET CT is a shade better. But if we go as far as the studies are concerned, if we look at the Myeloma 9 study, so which was done by the France group, they have clearly shown that MRI is not inferior to PET CT at diagnosis. But there are certain specific conditions where MRI can be done. If a patient has got neurological compressive symptoms or spinal symptoms, then MRI of the spine is better than doing a PET CT because that helps you for neurological interventions.
Yeah.
The next question that we have.
There is a question from Dr. Zinat. Plasma cell leukemia, how to differ?
Now, so ma'am, the question as far as I could not fully gather that are you talking about diagnosing plasma cell leukemias? So if we are talking about diagnosing plasma cell leukemias, the number of the cutoff for the absolute plasma cells have been brought down drastically in the recent times for plasma cell leukemia for the peripheral blood. And plasma cell leukemia that way is a much easier diagnosis when compared to any other disorders that we have spoken throughout the day, because a good morphologist in a peripheral blood should be able to pick up a plasma cell leukemia. But yes, one small bit of advice for all the budding pathologists or hematopathologists. So please just don't restrict to 100 cell count. You should ideally do a 500 cell count before labeling a patient as plasma cell leukemia or not, because it has got huge therapeutic implications. And we should identify these patients earlier, because the median survival of any patient with plasma cell leukemia is very bad. So it's very important to get to a correct diagnosis of plasma cell leukemia.
So one more question is there from Dr. Balaji. How can we know that if there is false positive report given by labs when we suspect and send for M protein in early stage? Please enlighten us.
So ideally, every patient of a protein electrophoresis should be complemented with an immunofixation. When there is a discrepancy between protein electrophoresis and immunofixation, and the third part of the triangle is a clinical setup. So if there is a discordance between the clinical bedside scenario, the immunofixation, and the protein electrophoresis, then you can actually think about a false positivity. But as I showed you, all the examples or the case vignettes, I have shown you around 10 case vignettes, which shows the various way you can pick up false positivity. So most of them are pre-analytical in nature, and with a good history and with a good lab support, they can actually come and tell you back that the patient most probably does not have a M protein. But the easiest way is to collaborate between protein electrophoresis and immunofixation. And the second way is to ensure doing a urine protein electrophoresis along with a serum electrophoresis. That will actually take care of most of the patients who have got a false negative or a false positive reports.
So there is one more question from Dr. Radhika Shetty, that PT relapses within 1.5 years post auto TX. While on LEN maintenance, a second auto TX versus LOTX after salvage CT, if auto, should we intensify conditioning regimen?
Again, this is a very, very good question. And in fact, I found the same question being asked to Dr. Maria around 2 days back on a Sunday Mumbai Hematology Group meeting. So first of all, role of second transplant, autologous versus allogenic, on today's date with the era of monoclonal antibodies is dwindling down. Now, allo transplant definitely for high-risk patients with high-risk cytogenetics and younger patients can be of help. Second auto transplant, particularly if a patient already has got stored cells with him. So as soon as you bring the patient into remission, a second auto transplant can definitely be done. Leave about second. While I was at Mayo, I have seen patients who have undergone third or fourth transplants also, as far as the autologous transplants is concerned. But if the patient is young, we should definitely consider an allogenic transplant. Though the role of allogenic transplant in elderly or in those patients beyond 55 years of age is doubtful. Now, coming to, should we intensify the conditioning regimen? Yes, that's an important question. We do not have clear answers for that across the world. People have tried various ways of intensifying the conditioning regimen. Some people have added the proteasome inhibitors. Some people have changed the type of the nitrogen mustard that we give. Some people have given higher doses. But as of now, nothing is in the guidelines, and it has to be tailor-made from patient to patient. But yes, with the availability of the various monoclonals, I doubt if we actually would have a greater role of second transplants in the future to come in.
So there is one more question. If M protein is 1G/DL, PT has CKD, SFLC normal, plasma cell 18%, what to label this case and how to proceed?
Now, as long as your plasma cells are clonal in nature and more than 10%, and a patient has got a renal dysfunction, even if the patient would have been CKD for last 5 years, 10 years, it still fits into myeloma. So any plasma cells, clonal plasma cells, more than 10% with renal dysfunction, we should not have any confusion as far as the myeloma is concerned. Now, many times, particularly India being the diabetes capital, at a bedside, we quite often see patients with diabetic kidney disease or hypertensive nephropathy having worsening of renal dysfunction and then diagnosed to have a plasma cell dyscrasia. Situation 1. Situation 2, many a times the patient at the evaluation for the chronic kidney disease never underwent an evaluation with a protein electrophoresis or a bone marrow upfront, and we detect after 2 to 3 years down the line that the patient has got a M spike and he has got associated monoclonal gammopathy. Then the patient has to be managed as a case of myeloma kidney in these cases. Okay, the same person also asked what to take kappa lambda ratio on IHC in patients with CKD. Now, there's a slight debate on this, but definitely the ratio of kappa lambda is not 1.65 that we routinely take. these people are known to have higher kappa lambda ratios because the excretion by the damaged kidney is different for kappa lambda when the patient has got a renal dysfunction. So certain guidelines say that up to 3 or 3.5 ratio can be taken, but again, it's not standardized across the world. But yes, the ratio up to a higher limit can be taken as a normal ratio. So in a patient with CKD who only has got a kappa lambda abnormality ranging between 1.65 to 2.5 or 3, there you should be extremely careful for labeling the patient as myeloma, because if the patient does not have plasma cells and if the patient has got no other slim crab criteria, then you should avoid labeling the patient as plasma cell dyscrasia and keep them under follow-up and repeat the evaluation after some time.
So I think there are no more questions. So can we wind up for the day?
Yeah, so I would like to apologize to everybody for the technical glitch that we had in between, and we had to interrupt the session. Otherwise, we would have completed this well in time because it was timed to be only for 40 minutes lecture, but we had an interruption of 10 minutes because of the poor internet connections and the technical glitches. I apologize for that, and I thank everybody for being a part of this discussion. Thank you. And I thank Riverroot for helping us out with this particular session, and ISHBT for giving this opportunity.
Thank you, sir. On behalf of Indian Society of Hematology, I would like to thank Dr. Uday Yanamandra, sir, and everyone for giving their valuable time. Thank you, sir.